All right, so welcome back to our lectures in Therapeutic Exercise 1. Today we're going to be going over Chapter 4, Stretching for Improved Mobility. In our last lecture, we talked about range of motion, the different types, active and passive insufficiency. So now we're taking it one step further. Remember how we talked about range of motion being a precursor for stretching. So now we're going to assume that we've kind of gone through all of our range of motion techniques, and then we're finally moving on to our stretching interventions. So you can read through some of those objectives. Let's talk about stretching for improved mobility. First, we're going to talk about just the definitions of flexibility. And the two that we really want to kind of be aware of and make note of would be dynamic flexibility, which is basically active range of motion. So the patient's moving their own limb through that full range, and it really requires some more coordination, definitely requires some elasticity of those structures. And then we also have passive flexibility, which is just passive range of motion. Passive flexibility is kind of like a prerequisite for dynamic flexibility. So maybe we're going to start with that passive flexibility piece, and then as a progression, we'll move into those dynamic activities, that dynamic flexibility. And then we go into hypomobility. So what is hypomobility? It's decreased mobility or restricted motion at a single joint or a series of joints. And there are tons of different pathological processes that are associated with hypomobility. And if you look in table 4.1 in your textbook, that kind of talks about some of those things. So in that table, it mentions prolonged immobilizations. If your patient is in a cast or an orthotic for a long period of time, that could lead to hypomobility. Or if they're on skeletal traction following some type of fracture and they're trying to realign it. Osteotomy, soft tissue trauma, those kind of things. And then also just prolonged immobilization due to joint pain, joint inflammation and effusion, muscle tendon or fascial disorders, skin disorders, bony blocks, vascular disorders. And then, of course, always if somebody is living a sedentary lifestyle and they just have poor posture habitually or asymmetrical postures, then that could lead to hypomobility of certain muscle structures, joints, things like that. And then, of course, we also have to consider neurological disorders, somebody with paralysis or tone abnormalities. They're going to present with muscle imbalances. So spasticity, rigidity, flaccidity, weakness, muscle guarding, or spasm can all lead to hypomobility. And then the next thing that we want to talk about are contractures. So what is exactly a contracture? It's the adaptive shortening of a muscle tendon unit and other soft tissues that cross or surround a joint that results in significant resistance to passive or active mobility, and it's going to present with decreased range of motion around those different structures. So again, all of those things that we talked about in table 4.1, if they are not addressed in a timely manner, could lead to these different types of contractures. So let's talk about contractures a little bit more here. So contractures, whenever we're trying to name a contracture or describe the contracture, we think about it as the side of the joint that has the tissue tightness. So what does that mean? Well, let's think about a flexion versus an extension contracture. Let's take the knee, for example. If somebody following a total knee arthroplasty is stuck in flexion and they cannot get full extension of their knee, we call that a knee flexion contracture. If somebody is stuck in extension following, a TKA or something like that, and they can't bend their knee, then we say that that is an extension contracture. It's stuck in extension. So you're going to have to know how to label those different types of contractures. And then on the kind of to go even further than that, what structures are we going to have to stretch in order to maybe combat these different types of contractures? So again, for example, knee flexion contracture, stuck in flexion, we want to stretch the hamstrings. If the knee is stuck in extension with an extension contracture, then we're going to try to stretch the quadriceps muscle group out. You may want to start this slide. We're going to talk about different types of contractures. So the first one that we see here on this page is the arthrogenic and periarticular contracture. So basically, this comes from an intra-articular pathology. So these changes may include adhesions, synovial proliferation, joint effusion, irregularities in articular cartilage, or when there's an osteophyte formation. Okay, so my example here is a total knee arthroplasty. So prior to the surgery, they may present with soft tissue shortening because of the osteoarthritis, and then they get the knee replaced, and they still have trouble getting full extension or full flexion of their knee. And that's because prior to the surgery, they were stuck in that position for a long period of time due to pain, due to those possible osteophyte formations. So it's going to be really tough to get back to full range of motion if they didn't have full range of motion prior to the surgery. So one of these contractures may have already formed, and they went through the surgery. Maybe their pain has decreased significantly because the two joint surfaces have been replaced, or the three, which we'll talk about later. But still, they may have limitations in range of motion that are permanent because prior to the surgery, they had those osteophyte formations. They had this joint effusion, and that led to soft tissue shortening. So intra-articular pathology, again, we're thinking the articular surface mainly here for this one. So you probably want to star that one because I'll ask about it on quizzes. Then we go to fibrotic and irreversible contractures. And basically, this is a fibrous change in the connective tissue of muscle and periarticular structures that is going to limit elasticity, possibly create adhesions between joints, and result in that fibrotic contracture. So again, this is, if we go back to our arthrogenic and periarticular contracture, maybe that decreased range of motion started out as something that we could reverse, but 2-3 years down the road, those fibrous changes have really impacted our patient's ability to gain new range of motion. So with fibrotic and irreversible, it's going to be really, really difficult to make significant improvements and change their decreased range of motion. Then we go to a myostatic contracture. And a myostatic contracture can be resolved. So these are the ones that we really want to identify early on and focus our interventions on resolving these so they don't move to that fibrotic and irreversible type. So basically what's happening here is there's the musculotendinous unit has adaptively shortened, and there's significant loss of range of motion. There's no specific pathology present, but we can actually reverse this limitation in range of motion just by performing our prolonged stretching activities, our PNF techniques, those kind of things. And then the last one that we're going to talk about here is the pseudomyostatic contracture. So basically what's happening here is there's impaired mobility, limited range of motion, or it could be a result of something like hypertonicity or spasticity, rigidity. And these ones are mainly associated with CNS lesions, such as a CVA, spinal cord injury, a TBI, those kind of things. So in this case, if we can address the spasticity, the hypertonicity, the rigidity, we may actually get some improvements in range of motion. So for these patients, it's going to be really beneficial to use those PNF techniques, which we're going to talk about in lab and a little bit later in this lecture. So out of these 4 contractures, I really want you to focus on the arthrogenic, periarticular contracture, and the pseudomyostatic contracture. Oh, there we go. So we're going to use neuromuscular inhibition techniques for that pseudomyostatic, which I hinted at with the PNF techniques. Okay, so now let's talk about selective stretching and overstretching and hypermobility. So the term selective stretching gives you an idea of what this really means. It's exactly what it sounds like. We're applying stretching techniques to some muscles and some joints while allowing motion limitations to develop in other muscles or joints. And this is going to be really important for our patients who have spinal cord injuries, TBIs, where there is spasticity and there's an inability to really make improvements with certain functional tasks. So we're going to talk about like a tenodesis grip here in a second. But basically, right, for somebody with the C6 spinal cord injury, they're going to lose their ability to flex their fingers, right? But they also still have the ability to extend their wrist. So as we extend our wrist, our fingers curl, right, due to this kind of essentially passive insufficiency of the finger flexors, and that allows them to grip certain objects just with wrist extension. So we wouldn't want to stretch out the finger flexors in that instance and create a ton of length there. We really want to allow tightness to develop in those finger flexors so that they can be functional with their gripping activities. And then we look at overstretching and hypermobility. So this is where there's a stretch well beyond the normal length of a muscle and range of motion of a joint and the surrounding soft tissues. That's what hypermobility really is, or if we're overstretching it, that's what the definition is. And sometimes this can be beneficial and it actually may be necessary for certain healthy individuals with normal strength and normal stability. And a good example of this is sports, and I'll have a picture of this here in just a little bit. But sometimes people need excessive range of motion in order to perform certain activities like sports. So we'll look at a couple images of that. But it's important to note that hypermobility, true hypermobility, due to Ehlers-Danlos syndrome, something like that, hypermobility is going to be a contraindication for stretching because that's going to create joint instability, and we don't want to make something more unstable if it's already super lax. So if we have a patient with EDS, then maybe we're just thinking of strengthening and providing stability to those joints, but we're not trying to improve range of motion because they already have too much of it. So here's a good example of that tenodesis grip on the top left corner here. So again, we are, in this instance, not going to stretch these finger flexors out, right? We want this to stay nice and tight. As we extend the wrist, you can see those fingers curl up, and that's what's going to allow some of our patients to actually grip, okay? And this bottom image here, just to kind of talk more about selective stretching, for somebody with a spinal cord injury, let's say they want to get into this long sitting position like this gentleman is here. Well, we can selectively stretch the hamstrings because we know they need to have length there in order to perform this long sitting activity. But we may allow tightness to develop in these spinal extensor muscle groups because this patient is going to lean into those tight muscles to help improve their support in sitting. So maybe we want to focus on the hamstrings for a stretch, but we allow some tightness to develop here on this section. Okay, so then let's look at this image over here on the far right side. So this is what we call a Lachman's test. This is testing for ACL laxity. So this is what true joint instability looks like here. Okay, so this isn't necessarily Ehlers-Danlos or anything like that, but this is true joint instability here that we're looking at. We're thinking this is a positive test for the a positive Lachman's test for ACL instability. This patient is going to have to go through surgical intervention, most likely, to repair that ligament or at least reconstruct it. But we're not going to go ahead and focus on flexibility here, prior to the surgery and leading up to that. If anything, we're going to focus on stability, strengthening, those kind of things. And here's another example of when we may want to overstretch an individual. So this is Aroldis Chapman, one of the best closers of all time, throws about 105 miles an hour. He's great. He was on my Cubs World Series championship team, so thank you for that. We borrowed him for a year for a heavy price, but we got the end result that we wanted. But you can see here, right, the angle of his shoulder. So normal external range of motion is about 90 degrees, which would be, if we stood him upright, probably about here, okay? So for this individual or these different athletes that play different sports, they have different requirements. We're going to need him to have a significant amount of external rotation in order to really pitch effectively. So this is one instance where we may overstretch to gain, more functional range of motion for this patient. They need it, right? So this is one instance where we may think about going beyond what a normal range of motion is. But because we are improving range of motion so drastically, we need to really focus on rotator cuff strength, stability of the glenohumeral joint. We can't just increase range of motion without strength. So we really need to focus on stability and strength of the muscle surrounding that joint. Okay, so here's a few just different interventions to increase mobility of soft tissues. We can perform something like manual stretching, which is passive. So, a therapist coming in, stretching into external rotation, using PNF techniques, those types of things. And then we can also use mechanical stretching. So something like a dowel rod, which can be passive or kind of assisted. And again, you can teach your patients PNF techniques on their own so that they can really benefit from those away from the clinical setting. So we'll kind of talk about those in lab when we get into our lab session. There's also self-stretching. So this is what they're going to be, your patients are going to be utilizing at home for a HEP. We really want to focus on these PNF inhibition techniques, extremely skilled interventions that PTAs can perform in clinic to help improve range of motion and mobility of those soft tissues. And the key word here is inhibition, right? We're going to talk a lot about PNF techniques this semester and next semester, and there are facilitation techniques, but the ones that we're going to focus on to improve range of motion include inhibition techniques. Okay, we're inhibiting muscles from firing that are restricting range of motion. Another one that you're probably going to see a lot of in clinic, because a lot of providers use these, are muscle energy techniques, or METs. And these are very similar to PNF techniques. They have some of the same characteristics, using isometric contractions followed by stretching. But muscle energy techniques are really well utilized to help improve postural alignment and range of motion. And it's kind of important to note that both of these here require the patient to participate more in this intervention. These aren't passive, is what I'm really trying to get at here. Your patient's going to have to contract isometrically, maybe concentrically. So there's going to be some effort here for these two compared to just a passive stretch. And then if we're really looking at improving joint position, joint range of motion, we can use our joint mobilization techniques. We're not going to use manipulations, right, because that's out of our scope of practice. And again, remember that it's really important that if you're performing joint mobilizations, if your State Practice Act allows it, that you are trained well by your supervising PT. And they check off on your skills and they ensure that you know what you're doing. Because the APTA, their official stance is that PTAs really shouldn't be performing joint mobilizations because in their eyes it requires a constant reevaluation of the patient, and that's something that's outside of our scope of practice. So we're going to learn some joint mobilizations. We're going to talk about the arthrokinematics a lot, but we need to make sure that when we're out in clinic, if we're going to be performing these joint mobs, that you feel confident and that your supervising PT feels confident in you performing that skill. And here's just a nice little refresher for the different grades of joint mobilizations. Remember, 1 and 2 are meant for pain modulation. 1 and 2 for pain. 3 and 4, those are the ones that we're going to actually focus on for improving joint range of motion. So again, don't need to know necessarily about this slide, other than the fact that you are going to use grades 1 and 2 for pain, grades 3 and 4 for improving range of motion. And that's all you need to know for now. There are also some other types of stretching techniques or just techniques in general that are going to help improve mobility and soft tissue elasticity. So in semester 2, we talked a lot about soft tissue mobilization, and pretty much all of the techniques that we learned had the benefit of improving range of motion and improving circulation. So we can use something like friction massage to try to break up adhesions. Same thing with myofascial release. So maybe using an instrument or like a foam roller or something along those lines. Acupressure mats, trigger point therapy, all of those can help improve soft tissue mobility. Now when we look at neural tissue mobility, we're gonna talk about these a little bit here. You may have heard the terms nerve gliding or flossing or something along those lines. Those can be really beneficial for your patients, but they can also really be irritating for certain individuals. So yes, we're going to talk about these. We're going to show you some different techniques that you can utilize in clinic, but it's not going to be a main area of focus for us. But again, we are going to introduce those to you and show you some different techniques. Okay, so indications for stretching, again, box 4.1, not to be confused with table 4.1. Box 4.1 tells you all of these indications that would indicate stretching. So obviously, if we see goniometry measurements that are below normal ranges, we are going to try to improve range of motion, right? We're going to stretch those individuals out, try to create more flexibility and mobility. Anytime that we have a surgical intervention or prolonged immobilization, there's a chance that adhesions and contractures can form, as well as scar tissue formation. So we need to be really cognizant of the fact that, you know, post-surgery, those kind of things, adhesions are going to be forming, especially if they're immobile. Contractures would kind of be the progression from the adhesions and scar tissue formation. But obviously, we need to put those patients on a really well-balanced flexibility program. Also, too, whenever there are structural deformities present or just poor posture that could lead to structural deformities, we want to make sure to improve and maybe use selective stretching to improve their posture. We talked about this one in our lecture. When there's muscle weakness and shortening of the opposing tissues, we're going to definitely stretch out those weak, shortened muscles. And then what I would recommend is that once you perform that stretching intervention, you use the new range of motion that you gain. So I think the example we used in our classroom was the forward head posture, forward rounded shoulders. So we talked about which muscles we would stretch, like the anterior muscles of the shoulder, the pectoralis major, anterior deltoid, the subscapularis. All of those muscles we're going to stretch, okay, and maybe load them eccentrically because they're still going to be weak, right? But we need to create length in those muscles. But, you know, after we go ahead and stretch, let's say, for example, the subscapularis, we want to really work on external rotation so that we can use that new range of motion to help improve the opposing muscle group. Stretching can be used to just help prevent injuries, and sometimes I don't really like this word prevent, but I do like the word reduce more so, because even if you are doing everything correct, you have a well-balanced flexibility program, you're doing strength training, you can't prevent injuries, right? They're going to happen. You see it happen all the times to your favorite sports players, and if you think they are not, you know, stretching, strengthening, then you're wrong. but we can help reduce the risk of musculoskeletal injuries. And we can also use stretching techniques before and after vigorous exercise. But again, here, when we talk about that passive flexibility versus dynamic flexibility, before an event where you're going to have to perform high-level activities, it's probably better to use something like dynamic stretching because you're doing those motions very quickly, right? Like high knees or something, or leg swings. Like that's going to facilitate muscle action at the joint that you're working. Because of that quick stretch, it's going to stimulate those muscle spindles, and then we're going to get better output from those muscle groups. Opposed to passive stretching, prolonged static stretching beforehand. Remember, we're using when we use prolonged tension, that really stimulates the Golgi tendon organs, those GTOs, and those GTOs, when they're stimulated, have an inhibiting effect on the muscle group. So maybe we include static stretching as part of like an ongoing program. They're doing it 3 to 4 times a week, but right before we're asking our patients to perform high-level activities, we really want to have that kind of dynamic stretching be part of their program. Okay, so next slide here are the contraindications. Star this slide. You're going to need to know all of these before you get into any of the quizzes, before you do any of your skill competencies. So you can go to box 4.2 in your text as just a different source to find all these contraindications. But the first one that we talk about is this bony block, or if there's osteophyte formation. We've learned about different end feels for joints, and if you come across a hard end feel before you're expected to reach one, or if you run into a hard end feel when you're expecting a soft tissue approximation or a soft end feel, that is an indication to not continue stretching, right? It's contraindicated to stretch that patient at that time. So we're not just going to blow through hard end feels, making the condition worse, causing loose bodies to break off in that joint space. Not good. So bony blocks or hard end feels, if you want to think of it that way, would be a contraindication for continuing stretching. Also, if there's a recent fracture, we want to make sure to avoid stretching, especially distal to the site of the fracture, because those muscles are going to attach proximally, and when you stretch those muscles out, they're going to pull on that fracture. Okay. Also, if somebody has a non-union fracture, a fracture that just hasn't healed correctly, and it's been, let's say 10, 12 weeks, it's still not healing. Yes, the time frame does allow you technically to go in there and stretch, but we have to consider this non-union fracture. Okay, so just moving right down along the list here. If there's acute inflammation or infection present, we want to be really cautious because stretching, range of motion, all those things are going to help improve circulation, things like that. And, it's good to improve circulation, but if there's inflammation or infection present, we don't want that inflammation or the infection to spread. So always look for those cardinal signs and symptoms of inflammation, infection. Make sure you notice if there's purulent drainage in the area, which would be indicative of infection, or a fever, elevated white blood cell counts. Like those things would be part of the documentation that you'd have to review to really rule out infection. Okay, sometimes it's not as obvious. If there is sharp or acute pain with joint movement or muscle elongation, then we're going to refrain from stretching. Hematoma or tissue trauma in the area. If there's hypermobility, again, you're thinking of Ehlers-Danlos or just hypermobility in general. Sometimes we're the first ones to really catch, laxity in joints, or if they had an injury and they haven't gone in for an MRI or something like that. Those special tests can be really helpful in identifying instabilities. And if you notice one, either from the initial evaluation or during your assessment of your patient, then we're going to X out stretching for that muscle or that joint, and we're just going to focus on strengthening and stability. And remember, selective stretching, right? If hypomobility, like that tenodesis grip, provides any type of functional benefit to our patient, then we're not going to go ahead and stretch it and make them less functional. So you're going to have to know all of these contraindications here for your skill competency and be able to identify them for testing, quizzes, things like that. And again, here's that one reminder of when hypomobility is actually a benefit to your patient. Okay, you can even see here, right? The fingers are flexed in that position. He probably doesn't have control over those finger flexors, right? So the wrist extension is going to help him. The tightness in those spinal extensors are going to help, but we stretch out the hamstring so that he can get into this position. Tons of different benefits, outcomes for stretching and flexibility. You can kind of read through those. We've talked about a lot of these already. But let's go down here to enhance performance. Okay, so we kind of mentioned this dynamic type stretching and like a static stretching beforehand. So this first one here, acute versus chronic stretching, we're thinking this is static. Hang with me as I write this out with my mouse, getting a little better with that. So these would be static, right? We can do acute static stretching, which would just be like what we do with our patients on a regular basis, but maybe they're only coming in one time per week, right? We're performing these static stretches. That has so much less of an effect than if you were to implement this into a long-term program. Okay, so 3 to 4 times a week, 30 to 60-second holds, 3 repetitions each muscle group. That would be considered a chronic stretching program, right? It's long-term. That's going to give you the most benefit for improving range of motion, okay? But if we are going to use this acute dynamic stretching, we're trying to actually facilitate muscle groups, okay? This is going to be active. It's going to be like your high knees. It's going to be your, they call them the Frankensteins, where you kick your leg out with the knee extended, and it's basically a quick hamstring stretch. So this acute dynamic stretching would be really good for somebody prior to activity. Chronic stretching, right, on their own, away from the clinical setting, is going to be better at improving range of motion. So we just have to know and understand when to use these different methods of stretching, and what is the goal of this stretch. Is it to improve range of motion like it would be here, or is it to improve functional performance, right? Are we stimulating those muscle spindles and activating the muscle before we're asking our patient to go through some type of high intensity activity? So you're really going to have to pay attention to those two there. Make sure you know this for the quiz. Okay, so properties of soft tissue. Whenever we're stretching soft tissue, it's typically elastic, right? It's going to stretch beyond its normal length, kind of like a rubber band would. We have this viscoelasticity, which basically just says tissue will deform with prolonged stretch. So a low load, prolonged stretch, we're going to see that deformation of the soft tissues. And what we're really trying to get to at the end game here is this plasticity. So the soft tissue assumes a new and a greater length. This is the goal for something like that chronic stretching program. We want permanent change, right? Plasticity means permanent change. So we are trying to improve range of motion in the long term, not just the short term. Whenever we stretch a tissue, right, it is going to elongate, okay? But the property of soft tissue is it's going to want to rebound and go back to its original length. So that's why the acute static stretching isn't going to be as beneficial, okay? So chronic program for stretching will improve range of motion, But again, we need to really use that new available range of motion in order to provide the most benefit to our interventions, such as flexibility. So let me give you an example here. So we're going to stretch out the hamstrings musculature. Okay, so we're creating length. Let's say our goal is to increase knee extension range of motion, right? That's what we're going to do when we stretch out the hamstrings typically. So in order to really maintain that new range of motion, we want to do something like along our quad, LAQ, the knee extension exercise, following our hamstring stretch to work into that new range of motion. Okay, so maybe that's the first time your patient has gotten to 0 degrees of knee extension after PNF stretching. They've been really diligent and they've worked on their own with their home exercise program. Now we want to make sure that we can fire up those quads and actively get full knee extension. So it's not just a passive intervention that we're performing, we're making this more functional, and it's going to benefit the quadriceps muscle group, right? They're going to be able to gain more strength because they have this new improved range of motion. So when you're thinking of this plasticity, it's the permanent change. We want to work into that new range of motion. That's the important part to know. And it's also important to understand, some of these properties of these non-contractile tissues, right? What are the characteristics, right? So collagen, we're going to talk about collagen, is really responsible for the strength and the stiffness of tissues. And we need to kind of understand, what is too much for stretching those collagen fibers out, what's enough. So this is important to know too, right? Failure of collagen occurs at typically less than 10% of an increase in that fiber's length. So typically, with soft tissues like collagen, they're in this nice little wavy pattern like this when they're shortened. Okay, they're kind of like this. And then so this is shortened, right? I'm just going to write an S right here for shortened position. And then when they lengthen, they straighten out, kind of like this. I'm going to write an L for lengthened. So they kind of start in this shortened position, nice wavy formation. And then when you lengthen them, they're going to stretch out and become this nice stiff, rigid, strong, soft tissue that is going to prevent overstretching, those kind of things. So if this increases by more than 10%, we have a high risk of that collagen failing, tearing, injury, those kind of things. Compared to something like elastin, which is what you see a lot of in the skin, this can stretch up to about 150% before it fails. So we just have to be really cognizant and aware of the fact that, yes, we are going to provide stretching for our patients, but we have to think of all the risk factors that would lead to maybe decreased collagen strength. Something like prolonged corticosteroid use would be something that you'd have to think about, right? The long-term use of corticosteroids actually inhibits the collagen, excuse me, clear my throat. Synthesis of collagen, right? So it doesn't really allow for collagen to form, and it's going to be weaker because of that. So maybe we don't want to take them to end range and do these ballistic stretching, like these really aggressive type movements. So just be really, really aware of some of those certain factors like prolonged immobilization, corticosteroid use, diabetes mellitus. All of those things can impact the structure of collagen and the strength. So you have to be careful. Another slide that you're going to star here would be these different types of stress. So let's just talk about these really quickly. So when we're thinking of tension, we're thinking this is really characteristic of tissue lengthening. This is what you're going to feel. You're going to feel tension in your hamstrings when you stretch them. Okay, normal sensation, but you have to educate your patients on, what to expect for stretching. You should feel some tension in your hamstrings or whatever muscle group that you're going to be stretching, but we don't want pain. Okay, so tension is okay. Then we also look at compression, right? This is typically seen with weight bearing. So compression typically is the right amount of compression is typically pretty good and actually helps facilitate muscle action. But let's talk about somebody who maybe has osteoporosis, who has a history of fractures, especially in the spine. We want to be really cautious with weight-bearing activities, not necessarily just related to only stretching, but strengthening, right? So compression can be good for bone health and muscle stimulation, but we need to be really aware of the fact that too much compression could actually lead to compression-type fractures in the vertebra, and it can also lead to compression-type fractures elsewhere, tibial plateau fractures, those kinds of things. And then the last one here is the shearing force. So this is when we have forces that are applied in opposite directions. Okay, so something along like this. So if we went back to that that little GIF earlier where the Lachman's test was being performed, we're creating a shearing force whenever we're testing for ACL laxity, right? I know this is upside down. Let me erase this really quick so I can mimic that test a little bit better. So let's say our tibia is here, okay, and our femur is here. So the Lachman's test was pulling the tibia forward, right? And the femur wasn't necessarily moving, but the joint surface is moving in the opposite direction as you pull the tibia forward. So this is creating a shearing force, and that ACL that sits right in the middle here typically prevents this motion. Okay, if it's torn, right, it's gone now, we're going to see excessive amounts of anterior translation, or that shearing force. This is why whenever we start looking at our ACL reconstruction protocols, we want to limit things like open chain knee extension early on, because the shearing force is going to compromise this ACL that's been newly reconstructed. So it's important to understand the forces, right, whenever we're thinking of our patients that have different pathologies, like I mentioned here, osteoarthritis, shearing force here after surgical intervention. And then it's important to just understand what tension means and educate our patients on what's normal to feel. So dig into these different types of stress. We're going to continuously talk about them throughout this semester. Summary of mechanical principles for stretching. Obviously, the tissue deformation varies depending on the magnitude, duration, and rate of applied load. So typically in our clinical setting, we're going to do low load, long duration holds to help improve range of motion. We need to think about healing and adaptive remodeling capabilities of certain tissues. So we do want to provide some tension and some type of stress to these tissues, but we need to understand what phase of healing somebody's in and how that tissue and the phase of healing affects the load that we're providing, okay? And again, I'm going to circle this one down here. Imperative that the individual use any newly gained range of motion like I mentioned earlier. So star that part right there, okay? Star that one, it's important. Okay, so changes in collagen affecting the stress-strain curve. We're not going to really talk about the stress-strain curve too much or in any detail, but there are some things that we need to understand. And I'm going to circle a few of them here, okay? So as it relates to collagen, as you age, that's going to decrease the maximum tensile strength and stiffness of those collagen fibers. So if you're working with an elderly patient or a geriatric population in your clinical settings, you probably want to increase stretching at a slower rate, decrease the intensity of those stretches, because again, the collagen fibers, especially if somebody is immobile, plus they are of significant age, I mean, their tissues are going to be a lot less resistant to any type of stress. So we need to always consider the age and understand that tensile strength, stiffness of those collagen fibers to provide stability is going to be much less than a healthy individual. And again, here's the corticosteroid use, right? There's always risk for decreased collagen synthesis and organization following long-use corticosteroid injections. And there's typically some necrosis around the area of the actual injection. So again, really have to pay attention to their past medical history, their medications list. Those will all determine the intensity and some of those other variables for flexibility and stretching. And the last bullet point here, typically when we're thinking of collagen fibers, remodeling typically begins at about 3 weeks post-injury. Moves from this type 3 immature collagen to this type 1 collagen, which is mature. So type 3 is going to be kind of like the filler as the remodeling starts to occur, right? Our body's going to lay down collagen fiber. It's going to be really weak. It's immature. And then as we start to get further along the healing process, it remodels into this kind of stiffer, stronger type collagen. But still, if we just have to consider the injury and the surgical intervention that was performed, because yes, 3 weeks is a good timeline for remodeling to occur, but by no means but it doesn't mean that it's mature enough to withstand certain loads. So maybe we can start to apply some load here for, let's say, like a total knee arthroplasty. But if we are looking at like a rotator cuff repair, an ACL reconstruction, we may be a little slower to progress some of these flexibility programs because the collagen just isn't strong enough yet to withstand some of those loads. All right, so continuing on with these mechanical responses of the contractile unit, let me write a little F right there, sorry. But the response to immobilization and remobilization, initially when we are immobilizing certain structures, there's a decay of these contractile proteins and a decrease in muscle fiber diameter. So that's going to lead to significant weakness, again, decreased strength and tensile strength and stiffness. There's going to be, again, atrophy and weakness of those muscle groups. And there is a chance that there's an increase in fibrous and fatty tissue in the muscles. This happens a lot in our patients that have low back pain, okay? Specifically this fatty, what they call fatty infiltrate. So I've looked at many MRIs of our patients that have low back pain and instability in their lumbar spine. And a lot of what we see typically is fatty tissue infiltrating where muscle typically should be, specifically of the multifidi and the rotatory muscle groups. So that's going to provide less stability to the spine. Okay, so they may be hypermobile. They may have decreased ability to stabilize their spine, perform balance activities, provide strength and power. So not saying that stretching is going to improve fatty infiltrates, but at least range of motion can help prevent this kind of fibrous tissue formation in those different sections of the spine or wherever else you're looking at. Just remember that fibrous tissue is not healthy tissue, right? It's not going to be as elastic. It's not going to withstand stress as well as normal healthy tissue. So this is why they've done lots of studies on early mobilization following a number of injuries, but including post-surgical injuries and interventions. We're going to help decrease the risk of fibrous tissue forming, which is going to decrease the risk of adhesions, contractures, and limited range of motion in the long term. And pretty interesting too here, when we look at the different types of muscle fibers in response to immobilization, these tonic or slow twitch type 1 muscle fibers atrophy more quickly. And you kind of wonder about that, right? It seems like it might be opposite, or maybe to you it makes sense. But if we are immobile and those slow twitch muscle fibers, remember those are the ones responsible for posture, those kind of things. They have a really high resistance to fatigue. Well, if we're not stressing them, again, remember the body responds to stress. If we're not stressing them, then why would they remain intact? Why would they resist atrophy? They won't. So postural imbalances are going to show up very quickly with immobilization because these tonic, slow twitch, type 1 muscle fibers atrophy at a quicker rate than those type 2. Important slide here, star this one, talking about the muscle spindles in the GTOs. So this is going to be really important to know for our PNF stretching. PNF, proprioceptive neuromuscular facilitation techniques. Okay, so let's talk about these really quick. Remember that the muscle spindle kind of lives in the belly of the muscle, and these convey information about muscle length, changes, and the velocity of those changes. So for our patient that has spasticity due to a TBI or a CVA, if they fall into this flexor posture and you're trying to pull their arm out of elbow flexion and you're trying to get shoulder extension, they may not do so well with the high velocity stretch. In fact, they won't do very well with the high velocity stretch because we're going to be facilitating those muscle spindles, and that is actually a facilitation of the action that you're trying to work out of, okay? So the more you pull on the wrist and the forearm to try to extend the elbow, if you're doing it quickly and aggressively, you're facilitating the biceps to contract harder and harder and harder. So you're going to have not very good success trying to move them out of that posture. Instead, we want to use something more like prolonged tension in the muscles to try to stimulate these GTOs, which creates an inhibitory effect. Okay, so you really want to understand and know the purpose and the goal of your stretch, right? And the pathology that you're dealing with. Because some people will respond to a quick stretch if you're trying to facilitate, let's say, triceps extension, something like that. And others are not going to respond very well to that, okay? So you may need to use something like a prolonged hold or tension in the muscle to increase range of motion. So what I also want you to write on this slide, remember too that when we're talking about our PNF techniques, we're going to talk about something called autogenic inhibition and reciprocal inhibition. So I'm just going to write an R right here next to the muscle spindles because this is what we're going to try to use to create reciprocal inhibition. And I'm going to write an A right next to here because we're going to try to stimulate the GTOs when we are using autogenic inhibition. Okay, so I'll give you a quick little spiel before I move on to the next slide here about what those two really mean. So let's try to get an example here. Okay, so let's say we're trying to stretch out the hamstrings. This is always a pretty easy muscle group to work with. Let's say we're stretching the hamstrings and we want to use something like reciprocal inhibition. Okay, so I'm stretching the hamstrings. I'm going to provide a quick stretch to the quadriceps muscle group. So I'm going to do a quick stretch into knee flexion while I'm still telling my patient to extend their knee, extend their knee, extend their knee, extend their leg. Okay, I'm going to stimulate the quadriceps muscle group. That allows the patient to get more knee extension because it's inhibiting the hamstrings at the same time. When one muscle group fires, the quads, the antagonist muscle group, the hamstrings, relaxes to get that knee extension. So that's what reciprocal means, basically opposite, okay? Now we can move to autogenic inhibition, okay? So still stretching the hamstrings. So if I am going to stimulate these GTOs and create tension in the muscle, I have to get the patient to contract their hamstrings, right? I'm trying to increase tension in the hamstrings muscles over a prolonged period of time so that it inhibits the hamstrings. And that will allow me to get better range of motion for knee extension. So it's always really hard to explain these on a slide. We're going to look at this in lab. So really pay attention to these and ask me questions, please, if you have any related to autogenic or reciprocal inhibition. Really important techniques. I kind of just went over this, so we're going to skip past this slide here. Some of the determinants and types of stretching, we're going to talk about these. All of these have to be present to get an effective stretch. So alignment of the muscle fibers that you're stretching will play an important role. Stabilization, typically of the proximal segment. The intensity of the stretch, we're going to say 2 out of 10 on a scale of 0 to 10 is going to be within normal ranges, and really up to 4 out of 10. Okay, so it shouldn't be too intense. It shouldn't be painful, obviously, for your patient. So those are the parameters we're going to use for intensity. The duration of the stretch, we're going to think about 30-second holds up to about a minute. So 30 to 60 seconds. For our prolonged holds, the speed of the stretch, it depends on what we're trying to accomplish, right? Are we trying to stimulate the muscle spindles and get reciprocal inhibition, or are we trying to stimulate those GTOs and get a prolonged stretch to inhibit the muscle action? So it depends, right? We could use both of those, but we need to know when to use them. And then the mode and the frequency. Again, if you're thinking of like a chronic stretching program, 3 to 4 times a week minimum. That was pretty bad, but that's okay. That says week, all right? So 3 to 4 times a week. What mode are we using? Are we using a stretch strap? So it's a little bit mechanical, but it's self-stretch at the same time. Like what are we doing, right? So it depends, but I would definitely look at these parameters here and know those ones for our skill competencies and our quizzes. Then we get into these different modes of stretching, kind of like what I mentioned earlier. So we have static stretching. We've been talking about that one quite a bit. This is a sustained period of lengthening. It's like the most common type stretch that we see. Then we have a cyclic or intermittent stretching, which is short duration, and it's repeated and gradually applied. Okay, so cyclic, intermittent, if you've ever done intermittent fasting, you know, you have these periods where you don't eat, things like that. Short duration though, okay? Not really sure if that made sense, but. And then we also have this ballistic type stretching. This is a rapid, forceful, intermittent stretch, and I think I have an image of one of those coming up soon. We have our PNF stretching, and then we also have mechanical stretching, like I mentioned with the stretch strap. So you definitely need to know what ballistic stretching is and what static stretching is. So here's a type of acute dynamic stretch, or a ballistic stretch, if you will. So I just kind of want you to think about this. I'll answer it here in a second, but I'll give you a little time to think. So which muscle groups are being stretched here? Okay, so hopefully you had some time to think about it. The adductors, adductors of the hip are being stretched because this gentleman here is abducting his leg forcefully. So that's a quick stretch, right? It's quick. This would be a facilitatory type action for the adductor muscle group. Okay, ballistic stretching, it's dynamic. So this would be a great exercise for him to do to improve hip stability, power, strength, all those kind of things, while still maintaining flexibility, range of motion prior to, it looks like he's playing football or something like that. All right, types of PNF stretching. I'm not going to explain all of these here on this PowerPoint, but your textbook definitely has all of these lined out for you and gives you an example of each of these, and it will be something that we do cover in lab as well. So let me find the page number for you here for this one. So starting on page 107 in your textbook is where they start talking about hold relax, contract relax, agonist contraction, and hold relax with agonist contraction. So I will explain some here, but I can't go over everything. It's just too much information for this one slide. But anytime you see the word hold with PNF techniques, that means that you're performing an isometric, or your patient is performing an isometric contraction, okay? Typically, we're thinking this one is going to be autogenic inhibition. So if we're stretching the hamstrings, we're going to place the patient in a pre-stretch position. So maybe they're supine and they have their leg in their hip inflection and their knee in extension kind of resting on your shoulder. You can tell the patient to push down into your shoulder, almost like a hip extension movement. That's going to stimulate the hamstrings, right? We're going to stimulate those GTOs, and we're going to have them hold it for about 10 seconds. Low intensity isometric contraction. And then we're going to tell the patient to relax, and we're going to move their limb into a passive stretch, a deeper passive stretch. So more hip flexion, more knee extension to stretch the hamstrings. Hold means isometric. Relax means it means relax. Okay. Contract, relax. We're also kind of thinking this is an autogenic inhibition type movement, but the contract means they're doing some kind of concentric contraction. Okay, so you're going to let the limb actually move, not to full range necessarily, but maybe you're having them actually bend their knee into your shoulder slightly. Okay, 10 seconds again, low load isometric, and then you're going to tell them to relax. And kind of like what we did with the hold relax, we're going to move them into more of a passive stretch. Now, when we get to agonist contraction, these terms can get a little confusing at times, but I'm going to do my best to break it down here for you. So agonist contraction, let's take, for example, again, the hamstrings, okay? This agonist contraction is typically performed with no added resistance like your shoulder or anything like that from the therapist. We're going to use this one as a reciprocal inhibition. Okay? So hamstrings. Let's say your patient is in long sitting on a table. They have a knee flexion contracture, which means they're stuck in knee flexion. Okay? The knee flexion contracture doesn't allow the agonist or the quadriceps muscle group to reach full range of motion. It doesn't allow it to shorten to its full extent. Okay? So in this scenario, the hamstrings are actually the antagonist muscle group, and the quads are the agonist muscle group. So we're going to use reciprocal inhibition. We're going to fire the agonist, which is the quadriceps muscle group, okay, to try to get more knee extension. As we fire the agonist muscle group, the quads, the antagonist is going to be inhibited due to reciprocal inhibition. So this works really well for like cramps and things like that. This is one that we teach all of our athletes. Like if they have a hamstrings cramp or something like that, then we tell them to fire their quads, because that's going to make or force the hamstrings to relax. Okay. And then we have a hold relax with an agonist contraction, kind of a combination of number 1 and number 3 here. So hold relax with agonist contraction. This is basically using the autogenic inhibition and the reciprocal inhibition at the same time. So still thinking of the quadricep or the hamstrings muscle group here, we're going to tell our patient to contract. We're going to tell them to contract the hamstrings muscle group. So, pull into my shoulder, push down towards the table, 10 seconds. They're going to relax after that 10 seconds. But instead of me, the therapist, pushing them into a new range of motion, they're going to use the opposing muscle group to gain new range of motion. So it'll look like this. The patient is going to push down into your shoulder for 10 seconds. You tell them to relax. And then directly after they relax, you're going to tell them to extend their knee. So use your quadriceps to extend your knee. So you're getting both reciprocal inhibition with That's the autogenic. You're getting both reciprocal inhibition, firing the agonist, the quadriceps muscle group, and the autogenic inhibition, firing the hamstrings. So it's a combination of both. So I know that's a lot. If you have questions after our lab session, please come see me and let me know. As far as preparation goes, we want to make sure to warm up the tissues before we stretch them. So a nice warm up, something aerobic, 5-10 minutes on a bicycle, on an upper extremity bike, treadmill, something to kind of get blood flow into those areas, create a little bit of local heat, so that when we go into stretching, everything's nice and loose. Again, we're going to stabilize the joints, allowing the muscles to be stretched, very important part. Explain the procedure to your patients, gain consent. Don't ever assume that it's okay just to touch your patients and do things that they're unaware of. Free the area from restrictions, which is what we talked about before, and tell your patient to relax as best they can. If there's muscle guarding, those kind of things present, it's going to really limit your ability to get a beneficial stretch. And there could also be some risk factors for re-injury if they are guarding. So tell them to relax as best they can. You can always do some relaxation techniques, breathing, rhythmical movements, such as rhythmic initiation, to help them relax. And once we have completed our stretching interventions, there are a few things that we can do to maybe make our interventions more beneficial. So once we're done, we can always apply cold to soft tissues, but we want to do that in a lengthened position. Okay? So let's take a total knee arthroplasty, for example. Your patients early on are going to really want support under their knee. Okay? They like to be in knee flexion, slight amounts of flexion at least. They don't like full extension. They don't like full flexion positions. They kind of want to be somewhere in the middle to reduce pain and discomfort, those kind of things. But let's say we have stretched the hamstrings out to gain full knee extension. We can apply a cold pack as they rest, but we want to make sure that we don't bolster their legs and provide knee flexion while they're icing. Because remember that elasticity of the tissues, once they stretch, they're going to want to return to their normal position. We can try to make this more plastic change by applying cold to those tissues in the lengthened positions. So if you stretch the hamstrings, don't put them back into a knee flex position when they're resting. You have to let them know this isn't going to be super comfortable, but this is what's going to be most beneficial for you. So always, if you're going to ice afterwards, do it in a lengthened position. Don't do it in a shortened position. You can have the patient perform active range of motion strength exercises in that newly gained range. Again, star that slide. I brought that up multiple times on this recording. And strengthen the antagonist muscle group in a newly gained range. Same kind of thing we were just talking about. So here's some general precautions for stretching programs. Not to say that osteoporosis is a complete contraindication, but you do want to be aware if somebody has osteoporosis. Remember that when we're stretching muscles, the muscles have origins and insertions on bones, and providing too much tension there can actually cause fractures, like avulsion fractures of the bone. So be really careful. Newly united fractures, there may be some protocols that allow for some stretching activities to take place. If the fracture has been, let's say, united by internal fixations like a plate, but again, you're not going to go full range of motion stretching with that person. You want to be really careful of a long lever arm because this creates greater torque. So again, this is why it's really important to stabilize proximal joint and provide stability to the distal joints. We don't want to, like for example, if we're stretching the hamstrings, right, and the only point of contact that we have is distal at the ankle and it's on our shoulder, that's going to create torque at the knee joint. So we want to stabilize that knee joint first. Okay, be aware of immobilization and the effects on collagen like we talked about earlier. Edema is going to play a factor. So maybe we're going to utilize stretching interventions with the leg or the limb elevated to help reduce edema. And again, that corticosteroid use is something that we have to pay really close attention to. And of course, there's always going to be these kind of mass market flexibility programs, and you just want to always educate your patients on, the possibility that their research that they're doing online isn't going to be most beneficial for them and their condition. So if they ask you about, some of these programs that they're on that they found online, you want to review that with them and make sure that it's going to be safe and effective for them. And here are some other adjuncts to stretching interventions. Relaxation training, Pilates, yoga, Tai Chi. We can use heat and cold. We can use massage. We can use biofeedback. And then we can also do joint traction or oscillation to help improve range of motion. So these are all adjuncts, right? Things that we can add to our interventions. And that brings us to the end of our lecture. So again, thank you so much for stopping by. Please give me a like, share it with your friends who are going through similar programs if you found this helpful. If you have questions, always feel free to reach out to me. Thanks for stopping by, and we'll see you for our next lecture.